In the realm of different clinical scenarios, ACS and STEMI, usually that's a place where everyone's moving really fast and imaging is not always top of mind. When it comes to OCT in these scenarios, what's the value of incorporating OCT into an ACS type of scenario?
In my practice, I have equal or more utilization of OCT on ACS than in stable patients, because I think it adds tremendous value. I think the two populations, STEMI and non-STEMI, have that own kind of commonality and difference. For the STEMI population, obviously you need to open the vessel prior to image, but this opening of the vessel, it only takes something like a TIMI2 flow on the vessel to be able to acquire OCT. Because it's interesting that that super severe lesion that you still have there, it has a component that is thrombus, and the contrast can still find its way and opacify distal in the vessel. So we run a core lab analysis for a trial called Octavia, and that was the protocol. As soon as you achieve TIMI2 flow, either by crossing with the wire or a small balloon, the investigator would OCT the vessel. And the question of the trial was, what's the etiology? Is this plaque erosion, calcium node, or plaque rupture? And in 80–90% of the case, we were able to with certainty, have that etiology determined.
Mm-hmm. So talk to me about, in these instances of ACS, we want to have at least TIMI2 flow to acquire our image. Once the image is acquired, what are the things that you're looking for right away on your OCT run to determine what the next steps are for that patient?
Yeah, so for the keeping on the subpopulation of STEMI, I think there is rarely a question on who is the culprit, right? That's the vessel that was occluded most often. So that's not a question there, but it is a question for the non-STEMI population, right? So the first thing that I'm looking at the vessel is that, that tight lesion here, there is no aspect of thrombus, there is no aspect of plaque rupture. I want to make sure that it's not another lesion that might be now less severe that is actually my culprit. Right. So you might run in a situation that you are treating a 80–90% lesion in non-STEMI, but your culprit is the 50–60% lesion. Okay. Right? So having the ability to detect thrombus, and we discussed this already, our sensitivity is 100% in detecting thrombus, really put you in a very strong position to determine who is the culprit lesion. Mm-hmm. Back to the STEMI situation, super tight lesion, you did your OCT run, and now you are scanning the vessel for amount of thrombus, distribution of thrombus versus plaque, right? So you might be in a situation that you see, there is a lot of clot here, but not necessarily a lot of plaque, and that might push you to do a little bit more of thrombectomy or even a less aggressive ballooning to fragment that calcium, and it might translate on your stented region become shorter, right, than you would if it was angiography only. So yes, that's the first thing that we look for.
So staying on the topic of STEMI and assessing the morphology, and you mentioned how the length may be shorter than initially thought. What about diameter and OCT in the context of STEMI and assessing what diameter stent you may need?
Yeah, so the length, just to emphasize this, yes, it can be shorter. It also can be longer, in the sense that your rupture plaque might be adjacent, and that's another thing that we saw this on the Octavia trial. Your MLA often wasn't at the site of the plaque rupture. So you're also gonna need to make sure that you are covering the site of plaque rupture. So if we answer the question about length, diving on diameter here, I think the key is to emphasize every time that you do OCT, you need to give a fair dose of IC nitro, right? And this is particularly important on the ACS population that comes already with a higher tonus on that vessel and spasm. So it's a paradox that sometimes I see people taking the time and make the investment on OCT, but forget about nitro. And we all know that your vessel can go from a 2.5 millimeters to a 4.0 just based on nitro, right? So it's really, really important that you image with nitro on board.
Wrapping up with STEMI here, let's shift gears to the non-STEMI population. What type of things are we looking for in a non-STEMI situation when we're doing an OCT run?
Yeah, so I would say that probably 20 to sometimes 30% of patients that present with a non-STEMI, the culprit vessel is not clear, right? And I think we have a tendency to start with the vessel with the most severe angiographic stenosis, but this vessel not necessarily is the culprit vessel. So that's number one. Consider imaging more than one vessel and identify your culprit. All other good practice apply for the non-STEMI. You should be doing also with nitro on board and following an algorithm like MLD Max.
A clinical scenario that I get, in the realm of ACS that I've seen a handful of times, and practitioners will see it probably, a handful of times in their careers, is SCAD. And while it's not common, when it does occur, there are a lot of questions around, can I use OCT in SCAD? If I'm using OCT, is there anything different that I need to be doing when I'm acquiring my image because it's suspected SCAD? And what am I looking for then on my OCT image to confirm that it truly is SCAD? So can you share your experience as well as best practice in this scenario?
Sure. So that's another topic that there is a lot of variability between operators. I mean, if you don't think of SCAD, you don't diagnose SCAD. So it always starts with physician experience and awareness that that's what they might be dealing with. If angiographically you have no question about SCAD, and you don't intend to intervene on the vessel, I would not recommend to systematically image. If you have question I think is very important for the patient to live with a proper diagnosis. And there are large series of combined, small series, but hundreds of patients that have been safely imaged with OCT. So typically this will be the type of scan that doesn't come with an angiographic flap. So the odds for you to be intraluminal is very high and safe. So a lot of nitrogen imaging as you would with good technique, good engagement. I would definitely avoid, the only situation that I would avoid is if you suspect that your SCAD is involving left main, because then, yes, the guiding sitting right there can accentuate the false lumen. Other than that, you should be very safe, and I think it's very important for the patient to have this diagnosis. How you interpret is very easy, is what we describe as hematoma.
Okay.
Right? So you would have a normal to close normal vessel, hematoma followed by adventitia. It is very, very easy to identify this on OCT.